If you don't think you can be hurt in a low-impact accident, think again.
Well, most people find it hard to believe that they could be seriously injured in a 15-mile-an-hour collision.
Most people don't understand the mechanism of transference of kinetic energy, kind of like one billiard ball hitting another. As one body weighing a certain amount transfers its energy through many, it then causes that energy to be released at the end. Watch Whiplash, the epidemic. Find out the facts behind whiplash. How did the injury occur? When did the first symptoms start? It's interesting to note that people of all walks of life have been to chiropractors. Definitely sounds like a pinched nerve. Let's do an examination and see what we can do about it. I explain anatomy, physiology. I let them have an understanding and comprehension of what is going on inside of their body. Let me test a couple of reflexes first.
Okay.
Good. This is the fourth lumbar reflex.
The most common cause for back pain is ignorance. Ignorance of the things that we do throughout the day that cause back problems.
What we're going to do now is we're going to take just a couple of x-rays. Chiropractic is a fascinating field and a wonderful history. If you look at your x-ray here that I just took, there's a curvature here right in the low back. If you pinch a nerve too long, you eventually begin to develop numbness, tingling, and long-term loss of function.
Terrific.
Okay,
Sounds good.
Good. We can begin right away.
Okay,
Great.
thanks.
Hello, I'm Dr. Clayton. I'm presenting material today on the phases of healing. This is a process by which all soft tissue heals and shows a procedure by which to most effectively treat soft tissue injuries. The body has three distinct phases of healing to them. Phase 1, Phase 2, and Phase 3. Phase 1 begins from the onset to between 2 and 5 days and is classified as the acute inflammatory stage. Phase 2 is anywhere between 4 and 12 weeks in length and is part of the remodeling phase or repair phase. Phase 3 can last anywhere from 21 days or 3 weeks to 1 year or more. Each one of these phases is specifically outlined by physiological activity. And this physiological activity then has specific protocols by which to heal them. Several years back, minding my own business, just sitting in my practice, reflecting upon the kind of people I treated, I realized that 80% of the people that I was treating for some sort of old injury that had healed improperly or had never healed at all. It was a curious point. I just tucked it away in the back of my head and forgot about it. About 2 years later, I began taking a review course in orthopedics. This is a 360-hour, 3.5-year course in orthopedics. At the end of this orthopedics class, Dr. John Black took 36 hours to condense the 360-hour course we had just taken, and the overview is which I am now trying to attempt to put into 1 hour. After completing my orthopedics course, I had been contacted by an insurance company to do some review work. I had never done insurance review work before and thought it was kind of curious, and so I thought I would try it. I called up one of the doctors that I'm aware of who was doing insurance review work and asked him to teach me what he knew. He was putting together a course, asked me to sit in on it, and with time, I began to realize that maybe all the things that people were cutting my claims for before were more my fault than the insurance industry's fault. The real question is why are the phases of healing important? Well, as I said before, 80% of my patients I was treating for an old injury. I had just finished a 360-hour course in orthopedics, and I was doing insurance claims review work. And here's what I discovered. What the insurance industry has learned by statistical analysis, we now understand by physiology. Physiology says that soft tissue injuries have 3 distinct phases of healing to them. Each phase is marked by specific physiological activity. And for each physiological activity, there is appropriate and inappropriate treatment methods. The insurance industry is saying to us, maybe not in specific terms, but in generalities, the goal for soft tissue injuries should be to restore the patient to full function and physician independence. Treatment that does not progress along as the body's own natural healing process progresses is inappropriate. And here's the big one: inappropriate treatment will not be reimbursed. That's why the phases of healing are important. There's a cost-benefit analysis as well. Patients respond quicker to treatment. There is limited to no disability. I find this interesting. In the state of Florida, a doctor cannot dismiss a personal injury case unless a disability impairment rating has been performed. If we've done our job, there should be no impairment. I think maybe we're not doing our job as well as current research shows us that we should be doing. Treatment overall is less expensive. And I'm referring to long-term goal. The patient does not have the residuals, so long-term ongoing care is no longer required. So let's look at a muscle. It doesn't matter what the muscle is, which muscle it is. It's a muscle. And let's say we tear that muscle. We can tear it through overuse, stretching, exertion. We can tear it in a whiplash injury. We can tear it in a slip and fall. It really does not matter how the injury occurred. This presentation is geared towards whiplash trauma. That's my area of expertise. That's where I've geared my education for the last 10 years. And so many of the references are towards whiplash injuries. If you can master whiplash, you can fix anything. As I said before, phase 1, classified as the acute inflammatory phase, is marked from the onset for up to 2 to 5 days. The physiology is hemorrhage, vasodilation, exudation, chemotaxis, edema, phagocytosis. And right about this time, the fibroblasts, or those cells that start secreting all of the material to help repair this process, they begin to migrate to the injury site. The chemical mediators for phase 1 are histamine, bradykinins, prostaglandins, proteoglycans, fibrinogen. Now here's the most important part, the clinical goal. What is it we're trying to accomplish in phase 1? Well, we want to control the bleeding. 2, we want to reduce the swelling. 3, we want to prevent re-injury. And 4, we want to reduce the pain. This has been handled primarily previously through the clinical approach of RICE, rest, ice, compression, and elevation. I've been taught a new acronym. It's called PRICES. We start off with protection. We want to protect the area. 2, restricted activity replaces rest. This is no longer where we just stop the person, put them in bed for 2 or 3 days. This is where we take their activity level and we reduce it to 20, 40, 60, 80% of what they have done in the past. This allows the tissue to heal properly. Of course, you know and I know. In severe cases, they will require bed rest and perhaps complete immobilization. But I'm referring to that 85% of the cases that we all see. Ice, compression, elevation, and support. So from RICE, we've gone to PRICES. phase 2, or the repair phase, can last anywhere between 4 and 12 weeks. This is marked physiologically by the debris elimination. Beginning, the body starts to chew up and dissolve the damaged tissue. Number 2, the fibroblasts begin to secrete tropocollagen. Tropocollagen is kind of like what the precursors are of proteins. Proteins have amino acids, make proteins. Tropocollagen makes collagen. And the fibroblasts are secreting this tropocollagen, laying down this foundation. It starts to plug up the hole, stop the bleeding a little bit, but this very immature tissue is being laid down, and the body takes this building block foundation and then builds from it. This process continues from debris elimination, fibroblast secreting tropocollagen, and then this tropocollagen begins to aggregate into collagen fibers. Looks something like this. All these fibers begin to lie down. As they're lying down, they orientate just kind of like the way they are. They stay there, they start to give structure and rigidity to the tropocollagen as they're aggregating into the collagen fibers. There's no real orientation to this material. It's kind of like a spider web, just kind of like laying down in all directions all at once. After this, these orientations of the collagen fibers begin. They occur along lines of stress, activity, and electrical stimulation. And they look something like this. They line up according to what is done to them. And if I could say nothing more and stop this tape right now and say this is what you need to be doing, this is the most important part of this entire teaching. The fibers lay down and stretch in the direction of the pressure. Whether it's stretch, contraction, electrical activity, these fibers line up in that direction. If you don't do this and you immobilize the area, the pattern stays kind of haphazard and less orientated, resulting in a fibrotic scar situation. During phase 2, the cells travel up to 3 centimeters. This is almost 1 inch. As they reach out like that spider web, reaching out and grabbing the surrounding tissue that's good and anchoring itself to it. If it anchors in a rigid position, and there's no motion here, that person becomes stiff, there's limited restriction of motion. We've seen this all occur. We've seen the person with the dislocated shoulder that they've wrapped up, locked in place, no mobility. 3 weeks later, there's no motion to it because the fibrotic adhesions have reached out to the surrounding tissue, locked themselves in, and now limitation has occurred. During this phase, that reaching out of the collagen fibers draws the material to close the wound up a little bit. The goal of phase 2, should be obvious at this stage, is to assist the body in the development of the collagen scar. The truth of the matter is we've made the mistake of making pain reduction our primary goal. It's not our primary goal. Our primary goal is to bring the person back to the full function of their body without the dependence upon us. Pain is one of those things that will subside as we accomplish this goal. The goal should be to lay the fibers up in the direction that is necessary to have the person heal best. During the phase 2, or at least the initial stages of phase 2, remember, this is between 4 and 12 weeks in duration. Part of our goal is to continue the phase 1 goals. We'll be weaning the patient from the phase 1 goals and weaning them into assistance of the development of the collagen scar. The question becomes, how? That's where the clinical approach kicks in. The clinical approach is accomplished through passive care. Passive care is defined as what a physician or a provider of healthcare services does for or to another person, as opposed to active care, which is defined as where the person does something for their own benefit. Passive care can include joint mobilization, modalities, and procedures. There are certain CPT codes assigned to each one of these, and you'll find them in the AMA guidebooks on CPT codes. Active care would consist of motion and progressive, keywords here, progressive resistance exercises. Too many times, we have all seen it. Too much too soon, rehab, or too little too late. And this is a guideline of simple motion, simple resistance, more active resistance, and that helps the collagen fibers develop in strength and tonicity to allow the patient to recover 100%. Phase 3 is classified as the remodeling phase. This is where the body undergoes the following physiological changes. The scar tissue continues to form. The tissue undergoes the continuation of tensile strength and rigidity. However, this must be progressively challenged in order to progress. If it is not continually challenged, and you bring the person just to pain relief through reduction of activities, a little bit of motion, and you do not continue through increased resistance activities, the collagen scar does not continue to form. The scar undergoes what they call functional linear alignment. It looks something like this. As the original scar tissues have been laid down, you started the patient through simple ranges of motion. As the patient can tolerate these and the inflammation has gone down, you have increased to resistance type exercises, and from there you've increased the person to active resistance such as elastic cords, free weights, something to challenge it. But you can't start too much too soon. It is a progression, and each person responds a little differently. The clinical goal of phase 3 is actually quite simple. You're here to restore muscle strength. How many times have we seen a patient released, and after they have been released, 3 weeks later, they were moving a couch, lifting an engine, cleaning a closet, and they tear the thing all back up again because we never brought the muscle tissue to strength, nor do we give the patient maybe the proper precautions that the tissue will continue to heal over a period of time. Instead, we write AMA disability impairment ratings. This person is going to receive 12% disability for the rest of their life as a result of this accident, and we never should have done it in the first place. We should have brought the patient through the healing phases all the way to the point of rehabilitation and strength, and thusly no limitations and no disabilities. Our goal at phase 3 is to return the patient to full range of motion. Now remember, back in phase 2, the first early stages, we're doing simple ranges of motion. Perhaps the person can only do 20% of their normal range of motion, but we're creating some degree of motion that is going to progress, key words, progress through the healing process. And our final goal for phase 3 is to limit adhesive scar formation. The clinical approach, as just discussed, passive care, joint mobilization, physical therapy and modalities, active care, resistive exercises, and restoration of full activity. Now, right about now, what I would love to do is say, during phase 2, for the first 4 to 6 weeks, if you send the bill across my desk and you've done XYZ therapy, I'm going to approve it. Each person is unique and different. And the truth of the matter is every therapy, every modality has some validity and some application to each and every phase. So it would be inappropriate for me to sit there and say, during phase 1, only do this, during phase 2, only do that. That's inappropriate. To sit there and put a burden upon somebody to lay down a cookbook recipe for every single treatment would be inappropriate. At this stage, maybe 6, 8, 10 weeks, if we have taken the patient from simple ranges of motion, progressively increased them to a little bit of active care, perhaps more frequency, perhaps with a little bit of resistance, and then we have them do some full range with some sort of full resistance exercises such as elastic cords, the scar tissue now has laid down the way it should have. There's more strength to it, there's more rigidity to it, it's stronger. However, if we don't lay it down that way, and we immobilize the area, and we put them in a cervical collar for 6 weeks, the scar tissue that lays down is so haphazard that there's no orientation to it. It just continues to grow out and grab onto everything, and now any motion that this patient does now creates a re-tear of that scar tissue. Thusly, new inflammation, new pain. It's this type of scar tissue that, when left unchecked, will result in long-term disability, reoccurring re-aggravations for the rest of this person's life. As a physician, I consider that inappropriate, and I will do everything I can to limit that. That's why I continued my education, received this information, and that's why I make it available to you. Let's discuss complicating factors. I mean, don't we all, I just wish that what I gave you was so perfect, that it would work in every single case under every single situation. But there are some reasons it won't. And here's one of them. Let's say the person was unaware of the impending impact, again, using the whiplash trauma as a mechanism. Say we have significant ligament damage. Now the area is unstable, it's going to take longer to stabilize it. This is a legitimate complicating factor and needs to be stated in the documentation so when it's reviewed by someone like myself, I have an awareness that the person was unaware of the injury. There is the likelihood, based upon x-ray evaluation, that there's ligament instability and this person is going to have a little longer period of time to bring them to a stable point. It's a legitimate complicating factor, but not if it's not stated in the doctor's notes. Body position at time of impact. Were they looking in the mirror? Were they digging something out of the floor? Were they looking over their shoulder? Well, 3 years back I had this acute case. Male, female, both sit in the front seat. He hears the screech. He looks up in his mirror and then looks over his shoulder just before impact. The passenger, who received a straight rear-end accident, was fixed in 4 weeks. He took 12. The ligaments were torqued, there was more strain upon it, ligament damage had occurred, nerve root compression had occurred, and all those things become complicating factors. And that's why he did not recover in 4 weeks as the passenger sitting right next to him. Such things need to be stated in your documentation. Was it a double impact? Again, using the whiplash illustration. Once they were hit from behind, did they then hit the car in front of them, magnifying the injury? Was the surface of the street wet, which allows the physics of the vehicle to move faster and thusly creating more trauma to the spine? Were they wearing a seatbelt? You know, these things save people's lives, and they are required by law in most states to be worn. But if they hold you in place and you go forward, then all the strain is being magnified into the neck. It is a consideration. It is a complicating factor. Impact direction. Was it a head-on, rear end, or side blow? This may describe why certain mechanisms of injury have occurred, why nerve root compression may have occurred. And if you do not describe in your paperwork these elements and some others, let's discuss injury components. Was it a severe injury? That's a complicating factor. Head injury. Do we have a head injury involved? A low-grade concussion that's complicating the recovery of this case? Was there an immediate onset of symptoms? As opposed to, well, 3 or 4 days later I started to hurt and ache. Or I had a little bit of a headache that night, but 3 days later I couldn't move. It's the immediate onset of injury that may indicate a higher degree of injury. Such things need to be stated. Severity of pain. You know, everybody hates the Mercy Conference guidelines. Most people have never read them. And they are in need of updating. However, they clearly state that the severity of the pain is a complicating factor. State it in your report. Patient complains of headaches. Out of a scale of 1 to 10, 10 tenths. The patient has not been able to sleep for 3 days, is on Novocaine, codeine, nothing's working. It's a complicating factor. Is there a disc involvement? If the person has a disc involvement, it may be wise to refer and apply other approaches. Patient component, complicating factors. Delay in onset of treatment. Well, if the person's going to walk in the door 6 weeks afterwards, the body's scar tissue is going to lay down, and it's laid down improperly. That's a complicating factor. This person may not recover in 4 weeks now. You may have to go in there and tear down the old scar tissue and then help rebuild the process. But this is no longer a 4 to 6 week process. This might be 12, but you had better explain. The patient delayed onset of treatment. They thought the thing would just go away. It did not. The scar formation has now formed in such a way as that treatment goal is now to tear down this scar formation, and this is going to add another 4 to 6 weeks worth of care, or whatever your clinical judgment opinion is. Deconditioned health. I just finished such a case. 9 months. What do you do with a 5'2", 300-pound person who never should have been doing the physical work in the first place? She's doing home health, the patient passes out, and as she's in this three-quarter position, lean over, grabs the person, strains the back. What could have been 6 weeks, 12 at the most, went 9 months. And the only reason it went 9 months is because in order to keep her out of pain, we had to actually bring the body up to a higher degree of muscular conditioning to stabilize the condition. In this case, I was lucky, and then the insurance carrier considered it reasonable to pay for such care. Not all carriers believe the same thing. Do they have degenerative joint disease? Are they a smoker? Are they more elderly? Do they have diabetes or some other systemic condition? Legitimate, complicating factors. How about prior injuries to the same body part? This is their 5th whiplash injury in 5 years. You know, this person may end up with a AMA Guides to Disability Impairment rating because of it. I wish it wasn't the case, but what do you do when you've got scar tissue on scar tissue on scar tissue, and the first 4 were never properly rehabilitated? Complicating factor. How about the failure to follow through on a treatment plan? We're doctors, we're physicians, we're providers of healthcare services, and based upon our clinical judgment, we say we want you to do this. But life, children, school, work, obligations in other areas all interfere with that individual's ability to follow through on your recommendations. This does complicate things, and is many times a cause actually for the denial of treatment by some carriers. If the person really was injured, is the general philosophy, the person would have followed through with care. If there's some life circumstance that is preventing the person from following through, perhaps you may need to dismiss the patient. Or perhaps you need to note in your documentation, patient is a mother of 3, full-time worker, sole supporter of her household, works many hours overtime, and is unable to follow through on a recommended treatment schedule. We have recommended and explained to the patient the necessity to follow through, but if they don't, they don't. As to whether the insurance company is responsible to pay for care is a per-carrier basis decision, not anything that any one individual can do and say this is going to apply to all situations. Treatment component. How about inappropriate self-treatment? You've seen them. Well, doc, I had this injury 3 weeks ago, and I've been sleeping on a hot pack ever since. Would you call that inappropriate self-treatment? I would. Or the person who put themselves to bed for 3 weeks. You wish it didn't happen, but they don't know any better. And this then complicates when they finally do come under your care on how the patient's going to respond. Inactivity or bed rest. Still a very common recommendations in most physicians' office, and yet every ounce of documentation says that complete absence of motion, complete bed rest is the worst possible thing you can do for a patient. Early aggressive rehab. The physician send the individual to a rehabilitation clinic. They did their exercises, they worked, they stressed, they've been in pain for 3 months and don't know why. Because the scar tissue couldn't lay down. Instead of doing simple ranges of motion, a little bit of activity that progressed, they started to person on some sort of resistance activity prematurely. and as a result of which the body never healed and stayed in a complete phase 1 and acute inflammatory phase the whole time. Case mismanagement. I have had the guts to write this in 2 of my reports, and I could have written in about 12. You just read the doctor's notes and you can tell that inappropriate treatment was done at inappropriate time, and it's just case mismanagement. Like I said, I've only had the guts to put it in 2 of my reports, but I have seen it quite a bit. Let's review. Soft tissue injuries have 3 specific healing phases to them. Phase 1, from onset to between 2 and 5 days, is the acute inflammatory phase. Phase 2 is between 4 and 12 weeks, and phase 3 can last from 21 days to 1 year or more. Let me interject at this point. Just because the body is physiologically healing at this time does not mean that the patient needs to be under some sort of in-office care. It just means that the physiology of the healing process is still continuing. Phase 1, the goal, is to control the bleeding, reduce the swelling, prevent re-injury, and reduce the pain. The therapeutic approach are prices, protection, restricted activity, ice, compression, elevation, and support. Phase 2, the goal is to assist the body's repair process in the development of the collagen scar while continuing phase 1 goals. And as you wean the patient from the ice and the restricted activity and you start increasing the mobilization, you then eliminate phase 1 goals and progress fully into phase 2. The therapeutic approach are active and passive care. Passive care, joint mobilization. Passive range of motion, doctor-assisted range of motion. Physical therapy, modalities, and procedures. Active care would be active range of motion, restricted activity that progresses towards full activity. Phase 3, restoration of muscle strength, full range of motion, and the limitation of adhesive scar formation. The therapeutic approach, passive care and active care. Passive care would be joint mobilization, physical therapy, modalities, and procedures. Active care would be resistance exercises and the restoration of full activity. Passive modalities may last between 1 and 12 weeks. Simple range of motion will be between 1 and 3 weeks. Light resistance and stretch from week 3 to week 6. And beginning by week 6, some sort of resistance exercise program should have been initiated. If we've done our job right, the patient then will be released. So here's the question. Do you want the linear scar formation to be along the direction of the muscle function? Or do you want it just haphazard, laid down, sticking, grabbing, pulling, and creating problems for this person the rest of their life? Now I've put this entire presentation into a poster form. The poster is designed for the physician to explain to the patient where they are, where they're progressing, where they're going to go to, and some reasonable time frame in which to accomplish it. There's no absolutes laid down because each person is an individual and needs to be treated individually. To some, they'll walk out your door within 6 weeks or less and have fully recovered. Others may take longer. If you wish to be reimbursed from an insurance carrier, you had better explain why it has taken past 6 weeks, what kind of complicating factors are involved, where the patient is, and where you expect them to go. This information is covered in greater detail in a video that I have produced on insurance billing. It's called, "I'm Getting Tired of Cutting Your Claims." And quite honestly, I am. So please, watch the video, learn, change, get your patient well. God bless.